Hi, for this lecture, we're going to jump over to chapter 13 and start looking at some of the structures of the PNS. Now remember, the peripheral nervous system is everything except for the brain and spinal cord. And when we look at the peripheral nervous system, it's mainly carrying information either to the brain and spinal cord, or it's carrying information away from the brain and spinal cord. And so this information is termed based on where it's coming from or going to. We have the somatic or visceral, two divisions of our afferent divisions. Remember that afferent means going towards, so this is always sensory. If sensory information is coming from skeletal muscle or the skin, it's going to use somatic sensory neurons. So again, it's going to use those afferents, and they'll be termed somatic. So our sense of touch when we're looking at muscle stretching. If the information is coming from maybe your urinary bladder, where you feel the urge to urinate, or from your stomach telling you you're hungry, that's going to come in through the visceral sensory division. Now the motor information is going to leave through, again, motor or efferent division. If it's going to skeletal muscle, remember it will be called somatic motor, and we studied that already when we looked at skeletal muscle, somatic motor neurons. If it's going to cardiac muscle, smooth muscle, or glands, then we're going to be using the visceral, which is usually called the autonomic nervous system. So you're using the autonomic motor, and again, that's going to your involuntary structures. When we look at the PNS, it's going to consist primarily of spinal nerves and nerves. So we have cranial nerves, remember, and we have spinal nerves and ganglia. So these are the structures that are outside of the CNS. So remember, a ganglion is a cluster of cell bodies outside of the CNS, or we would say a cluster of cell bodies in the PNS. And you've already learned one of those, right? You learned the posterior or dorsal root ganglion. That was outside of the spinal cord. Right, so that's a dorsal root ganglion, and that was a cluster of cell bodies of sensory neurons. So remember, our cranial nerves are called cranial nerves because they come off of the brain, and we have 12 pairs of cranial nerves. So again, these are part of our peripheral nervous system because they're coming off the brain and going to the effector. These nerves, remember, can be sensory, motor, or mixed. Sensory means it's only carrying sensory information in. And hopefully you remember your 3 sensory nerves. And the 3 sensory were your 1, 2. Remember, 1 was olfactory, 2 is optic, and cranial nerve 8. You can call it auditory or vestibular cochlear. Cranial nerves can also be motor. Remember, motor are only carrying information away from the CNS to an effector. And our motor nerves, our motor cranial nerves, mainly controlled our eye muscles. So we had 3 of those going to our eye muscles, and then we had a couple going to like your trapezius and your tongue. And then the remaining were all called mixed nerves. Remember, mixed nerves are going to carry both sensory and motor information. When we look at our spinal nerves, so you have a spinal nerve here. Remember, by the way, that the spinal nerve, you have the nerve, and then remember, it separates into the roots, and that the roots are going to be strictly sensory or motor, but all spinal nerves are mixed nerves. Now, they come off that cord through those holes, right? The intervertebral foramen, and that's how they're going to leave the spinal cord. They're pretty cord-like. They vary in size. The largest spinal nerve is actually your sciatic nerve, which we'll study soon. It's about the thickness of your little finger. Now, the nerves are set up kind of like muscle. When we're looking at nerves, we're looking at these axons here. And so you have the axons, and they have a connective tissue covering that surrounds them called the endoneurium. So the endoneurium is kind of like the endomysium in muscle. So the axon has the myelin sheath, and then the axons are surrounded and held together with endoneurium into a bundle, which is called a fascicle. The fascicles are all held together and anchored with perineurium, And then the epineurium is the outermost layer that surrounds the entire outside of the nerve. So you can clearly see these fascicles here. There's some blood vessels that always run inside the epineurium. So the epineurium surrounds the fascicles and the blood vessels. When we look at spinal nerves, as we said, that they're going to be connected to the spinal cord through the two roots. So what you're seeing is your vertebra. You can see the cord here with that gray matter like a H or a butterfly. You can see the spinal nerve and then the nerve roots, how they separate. So those roots are going to fuse together to form the spinal nerve. And again, remember that those roots are either dorsal roots or ventral roots, and that tells you what they do. So if we're looking at the dorsal root, remember that sensory information comes in dorsal. So dorsal roots technically have axons of sensory neurons. Ventral roots are going to have axons of motor neurons. Okay, so the roots are either sensory or motor, and then they fuse to form the nerve. Now, what happens is the nerve is pretty short-lived. So again, here you can see your roots, and then we have our nerve. And then what happens is the nerve kind of has these branches that come off them called a ramus. So we have what's called the ramus, the nerve, and then the root. Now, the rami is plural. There's 3 of these rami. So there's the rami communicans, there's a ventral ramus, and there's a dorsal ramus. Now, we'll talk a lot more about the rami communicans in more detail in chapter 14, but the rami communicans is a really important method that your sympathetic nervous system uses to send information out to its effectors. And so, if information is trying to go out from your sympathetic, it needs to travel through nerves, so it just uses your spinal nerves, but this is the way that's able to communicate. The ventral ramus is just what it sounds like. It's going to go toward the front of the body. You can call it ventral or anterior, and the dorsal or posterior ramus is going to go toward the back. So we look at the rami communicans. Basically what they do is they're transporting these axons. So if we look here at the ventral horn, remember we said that actually, let me back up for a moment. There's a ventral horn and then there's a lateral horn. Let me use blue like I do in the picture here. We'll try to keep this the same. So I'm going to use the blue for the lateral horn. And the lateral horn, remember, is autonomic or visceral motor. That's where the cell bodies were for autonomic neurons. So if the cell body's there, the axon leaves and the axon comes out the ventral root. Now the red one here is just showing you your typical somatic, okay? And we know that the somatic cell bodies are here in the ventral horn. And then same thing, the axon goes out the ventral root. And you might remember that we said that we talked about this these visceral motor neurons and the lateral horn, that the lateral horn was only in your thoracic and lumbar areas. But what I want you to look at is what can happen with these axons. So we have the axons leaving. There's my spinal nerve. And now you see these 3 branches, right? Basically my rami. Now the one that's going toward the back is the dorsal ramus. Then there's this piece on the front here. And what you see is the axon comes out and it's trying to get to this sympathetic ganglion. So again, ganglion cluster of cell bodies in the PNS. So there's a bunch of cell bodies of neurons associated with your sympathetic nervous system. And so there's a white ramus and there's a gray ramus. And the white ramus is myelinated. That's why it's called white. And the gray ramus is unmyelinated. I don't know why it's set up that way, but that's how it is. And if we look at the picture, we see that we'll follow this blue axon, comes out. Notice it leaves the spinal nerve and it travels to the ganglia. And it travels to the ganglia through the white ramus. So the white ramus carries the axon to this ganglion where it's going to synapse. Then it's going to activate another sympathetic nerve. It's going to activate sympathetic nervous system. And a lot of times they travel back through your spinal nerve. So the way they go back to the spinal nerve is they go back through the gray ramus and rejoin it. So I like to think of the white ramus as like an off-ramp of a highway, and a gray ramus as the on-ramp. So you get off, right, do your detour, in this case it's a synapse, and you go back on the nerve through the on-ramp. So they're just a way to relay information regarding the sympathetic nervous system, and we talk a lot more about that in chapter 14. Now, we also are going to have the dorsal ramus, which you can call it posterior. So notice in this case, I'll go back to the red. I've got my cell body and my ventral horn there coming out my ventral root, comes into my spinal nerve, and then this one is going to my back. So any information going to the skin and muscles of your back is going to leave and go back straight back through that ramus. Now, the rest of it is called the ventral ramus. So I either go off the rami communicans only if I'm dealing with the sympathetic nervous system. So remember, we're looking at our thoracic and lumbar areas. If I'm trying to send information to my skin or muscles of the back, it splits off the dorsal, or it just continues on and it forms the ventral ramus. And the ventral ramus actually wraps around and forms most of the nerves that you think about and that you've learned. It forms these nerve plexuses, or plexes, supplying pretty much your whole body. And so a plexus is a network, a mass of nerves, and we have 4 nerve plexes. We have one up in our neck called the cervical. We have a brachial one. We have a lumbar and a sacral. So these are the primary plexes that form from the rami. Now, what I want you to know about each plexus is I'd like you to know their name. You don't have to memorize the exact nerves, but I'm going to give you 1 to 3 nerves from each plexus that I would like you to memorize. So for your cervical plexus, I want you to know the phrenic nerve. Now, the phrenic nerve is the nerve that innervates your diaphragm. So when your diaphragm, right, when the phrenic nerve goes to the diaphragm and releases acetylcholine, that's what makes your diaphragm contract so you breathe. If your phrenic nerve fails to work, then your diaphragm fails to work and you don't breathe. And if we look at where it comes off, you can follow it all the way up here and you can see it's right around C3. So if there were any kind of spinal cord trauma, right, C1 or C2, it could cut off information to the phrenic nerve and then you would have to be on a ventilator. Now, notice this is a network, right? This is a plexus, which is actually good because if it was just a one-to-one relationship, right, you'd have a problem. So, for example, if there was an issue down here around C4, notice C4 still has branches and so does C5 going out to the phrenic nerve. So a lot of times these nerves get innervation from multiple segments of the cord, which is protective. Now, the brachial plexus kind of crosses through a lot, like right on your axilla, your armpit area, and the anterior shoulder. And this is mainly supplying our upper extremity, and you may have heard of some of these nerves before. We're only going to look at 3 of these, the median, the ulnar, and the radial. So I'd like you to know that those nerves, so we have radial, median, and ulnar, and they're pretty much just what they sound like. The ulnar nerve is by the ulna, so it's the medial one. The radial nerve is the one by the thumb, and the median is the one in the middle. So these are nerves that are going to innervate our forearm, wrist, and hands, and our arms. Now, the radial nerve, again, it's going to be thumb side. So think of this as it does a lot of what are your wrist extensors, so extending your wrist. Your ulnar nerve, on the other hand, is doing your little finger side. In fact, your ulnar nerve passes right behind that medial epicondyle. So if you've ever hit that, we call it our funny bone, although it's really not very funny, is it? It kind of hurts. You feel that sensation all the way down into your little finger and your forearm. That's the ulnar nerves that might help you remember. The ulnar nerve basically is going to supply your small finger and your ring finger, where your radial nerve is going to be your thumb and usually your first finger. Median, we're just going to do mostly in the middle. So we'll just say towards your middle finger for that one. But these are some important nerves in the forearm. And this just kind of shows you an image of the hand. You don't have to memorize all the digits, but it kind of makes sense where they supply. Moving down, we have the lumbar plexus. So the lumbar plexus, the big nerve here, is the femoral nerve. And the femoral nerve is the main nerve, if you look at these muscles here, going to your quadriceps. So anterior medial portions. So this is a very important muscle that is going to help you flex your hip and extend your knee. So if you had damage to your femoral nerve, you would have problems walking. It'd be very difficult to walk normally because of damage to that nerve. And then the sacral plexus, see how these nerves come right out, those sacral foramina? So you might have wondered why there are all those holes in the sacrum. These are the nerves that are going to go to our lower back, our pelvis. The largest nerve here is the sciatic nerve. It's a really big nerve, as I mentioned, about the thickness of your little finger. And it actually comes down, it passes through the greater sciatic notch to your posterior, your gluteal area, your thigh, and then it actually goes down your lateral leg into your foot. So if someone has issues, we talked a little bit about sciatica before, that's an inflammation of the sciatic nerve, you can get this radiating pain all the way from your gluteal area down to your foot. Now, you might have heard of a neuropathy before. It's kind of a general term for a nerve not functioning normally. So you usually lose sensory or motor function, so you might not feel anything. It might be numb. It might be difficult to move. It's usually due to some sort of trauma in the area or compression, especially if it cuts off the blood flow. Because if the neuron doesn't get oxygen and glucose, the neuron basically stops working. And we've probably all had this happen when we've sat in the wrong position for too long. You notice your limb falls asleep. Well, that feeling of falling asleep is because the blood flow's been restricted. And you might notice you can't feel it anymore, right? It's numb. And so that's what's happening is you're having a peripheral neuropathy. Now, these can happen as well from, like I said, trauma, or if someone has diabetes mellitus, if it's not controlled, the glucose can actually damage those nerves. And you might know when it falls asleep and you wake it up, you kind of shake it, right? You get that pins and needles feeling. That's basically the nerve like waking back up again. Now, a dermatome is a specific region of the skin innervated by a spinal nerve. So it basically makes a map of the body. So you can see all the areas, for example, that are supplied by spinal nerve L3. Or you can see here, it looks like C6. And so it makes a map, which is really helpful diagnostically. Let's say that maybe there's some sort of suspected trauma to the spinal cord, or you're suspecting nerve issues. What they can do is they can use light pins or touch, and they can kind of see, is the sensation the same on both sides of the body, or are you numb on one area? And so it's just a good way of diagnosing issues with spinal nerves based from testing you can do right on the skin. We do know, however, that shingles, which is herpes zoster virus, shingles hangs out in the dorsal root, ganglion. And so what happens is a lot of times when your immune system is compromised, maybe you're stressed, the virus erupts and it usually goes across a single dermatome. So because the dermatome is showing you the level, right, the spinal nerve, that area of the skin, if the virus is in that particular dorsal root, then it will infect the area of the skin from that specific nerve. And that's why you can get the shingles, which can be very, very painful. We also need to talk briefly about reflexes, and we'll test some of these in lab, but you probably know a reflex is an automatic response. So it's a predictable response. We're going to have sensory neurons bringing the information in, motor taking it away, and sometimes we have an interneuron. Remember, an interneuron is between a sensory and a motor. So we can have simple reflexes and complex reflexes. So the first thing we talk about is a reflex arc. So what is that? Well, these are just the steps for a reflex, and they're pretty similar to the steps we looked at when we first looked at the nervous system. So step one, you got to have a threshold stimulus and it activates a receptor. So the receptor forms a nerve impulse. Then it's going to send it through a sensory neuron, right? You can see the neuron coming up. There's the cell body and the dorsal root ganglion. There's the axon going into, right? Here's the dorsal root going into the cord. So we go to the CNS. This is where it's processed. Some reflexes only involve the spinal cord. Some are also going to send the information up to the brain, so they'll have an interneuron there. So you can see the interneuron in between. Sometimes the interneuron relays right from the sensory to the motor. Sometimes it crosses over, information, remember, crosses over in the spinal cord and goes up to the brain if it involves the brain. Now, when we have the motor neuron carrying information away, that neuron gets activated and that takes it out to the effector. Now, the effector, the ones we'll look at, will be mainly muscles that are replying or responding, but you can have glands. There's all sorts of things that are effectors. So when we're looking at reflexes, we have different ways that they're classified. So the classification is by development, site of processing, nature of the response, how complex they are, and which side of the body. So if we're looking at reflexes, if we're looking at development, basically you have innate reflexes that you're born with. So babies have a rooting reflex. If you stroke the side of their cheek, they'll turn their head in that direction. They have a sucking reflex. Or you can have a learned reflex. So you basically have a learned reflex of walking. When you walk, you shouldn't have to be thinking about it too much. You probably have driving reflexes and texting reflexes and, motor skills that you've learned that are reflexes. As far as the site of processing, this is where we're talking about, is it a spinal nerve or a cranial nerve? So what kind of processing occurs? Is it just in the cord? So these are spinal reflexes, or are you testing a cranial reflex? And that kind of goes along with the nature of the response, because you have a lot of somatic reflexes with skeletal muscle, or you have autonomic reflexes. These are things, again, heart muscle, right? Cardiac muscle, glands. So what kind of tissue? What's the effector? Complexity, is it one synapse, which means you're going right from a sensory to a motor, or is it polysynaptic? Do you have a sensory and then an interneuron and then a motor neuron? And then ipsilateral and contralateral just refers to the fact is, does the response occur on the same side as the stimulus or on the opposite side? So most of them will be ipsilateral, which means that it's happening on the same side. So we talked about the reflex arc, and now we're going to go ahead and jump into some reflexes and think about this pathway. So the first reflex is called a stretch reflex, and this is found in all of your skeletal muscles. And the receptor is called a muscle spindle. So the muscle spindles detect the amount of stretch on a muscle. That's their job. They're little muscle spindles. They monitor stretch. When the muscle is stretched, that's what activates it. Okay, so the stimulus is a stretched muscle. It activates the reflex. So now the sensory information, see how it comes in? Notice this goes directly to a motor. No interneuron in this one. Here goes the motor neuron carrying the information out. And so there's always two things that are going to happen when this reflex kicks in. Number one, it's going to make the stretched muscle contract, because if you're stretching it, you don't want to tear it. And the other thing it has to do is make sure the antagonist relaxes. Remember, the antagonist is on the opposite side of the joint. So when the muscle contracts, the antagonist must relax so you don't tear the muscle. These are monosynaptic, one synapse, and ipsilateral. So this is our knee jerk reflex or patellar reflex. When you strike the patellar tendon with the reflex hammer, it activates the muscle spindles. It sends the information in, comes out. It makes the stretched muscle, which is your quadriceps, right? Your quads. They're going to contract, and it's going to cause or allow the hamstrings to relax. Otherwise, you would tear your hamstring. And obviously, it's on the same side of the body, right? It's not like you strike your right knee and your left knee jumps out. So this is happening. This can be tested on any skeletal muscle when you do the little reflex hammer. When you strike it, you activate the muscle spindle. The stretched muscle contracts to prevent it from overstretching, and the antagonist relaxes. And this is what happens for posture. When you're trying to stand up straight, you might notice you sway from side to side. So you basically sway one side, and then when you stretch the muscles, it pulls you back to the other side. So these also help us with posture. And then we have the Golgi tendon reflex, very similar, except this is called the Golgi tendon organs, and these tend to be found in tendons. Remember that tendons connect muscle to bone, and so they're constantly picking up the tension in a muscle. So anytime you have a really high amount of muscle tension, this reflex makes the muscle relax immediately. So it's an inhibitory reflex. It's going to make the muscle relax. That reduces the tension and allows basically the tension over the Golgi tendon organ. So in this picture, you can see this particular reflex. You can see that the information comes in through the blue. Here goes my sensory in. Notice this one has an interneuron, and now it's coming back out, and it's going to as well help that muscle relax. These are done a lot in physical therapy when you hear about like pressure points. When you apply pressure in certain areas, you can activate the Golgi tendon reflex. And when you activate that reflex, that's going to make that muscle relax. So it's done a lot with muscle tension. Now, withdrawal reflex is something painful. You've all touched like a hot pan or a hot stove and you pull the limb away. So it's pretty obvious it's pain, and it makes you withdraw the limb away from the pain. Now, notice for this particular one, most of them are going to be polysynaptic, and it's ipsilateral. So it makes sense, right? If you touch it with your right hand, you don't say ow and pull your left hand away. So its job is to remove the limb, whether you touch something with your hand or if you step on a tack or step on something sharp. We're going to go with stepping on something for the last one, the crossed extensor. And so this is typically when you're walking and you step on something. And so it has two parts. It has a withdrawal reflex. So you step on something, in this case with the right foot, you're going to pull the right foot away from what you stepped on. But it also has a crossed extensor. So it has a contralateral extensor. So what that means is the muscles on the opposite side of the body are going to contract. So it has an ipsilateral withdrawal reflex and a contralateral extensor reflex. So it's many, many interneurons involved. And this is what allows us to balance when we have to do the withdrawal reflex, because otherwise you would step on the tack and then you would fall over because the muscles would not contract to hold you in place. So those are some of the reflexes. We're going to look at the stretch reflex when we're in lab, and we'll also experiment and do a spinal reflex as well as a cranial reflex. So this concludes our lecture on the spinal nerves and plexes and reflexes.